part of it, and we would like to hear from you, Dr. Mehta, your experience on this bowel endometriosis. Please go ahead.
Yeah. A big thank you to all of you from IAG for having me over at this event. And I have been asked to speak predominantly as far as managing complications for bowel endometriosis is concerned. So I will start off. I will, as most of the times, I have stopped showing videos at all these places because multiple videos are now available across social media platforms. If possible, I'll try to draw and tell some things which we need to remember when we are operating on a bowel complication, basically. And we also need to remember certain things which we need to follow in order to avoid a bowel complication. So these are the two broad things which I'll be speaking about. But just in case somebody is in a hurry, as has always been, I'll start the lecture with take-home points. Okay. So the 3 or 4 important take-home points about managing bowel complications is concerned. The first thing you should remember is that a bowel which has been repaired, okay, has to be a relaxed bowel, and that means the mobilization of the bowel is extremely important in order to achieve sufficient relaxation and extremely good healing for the bowel. And that is something which is very, very important in any bowel surgery, be it endometriosis, be it colonic surgeries, be it hemicolectomy, segmental bowel resection, discoid excision, whatever bowel surgery you do, the site of anastomosis has to be relaxed and it has to be tension-free anastomosis. That is an important point which will help you drastically reduce the amount of leaks and the amount of bowel injuries which you may encounter during your practice. That is the first point. The second important take-home point is if the patient is having a persistent non-settling tachycardia, pulse of the patient, post-surgical. If the patient is complaining, if the patient's monitoring criteria is demonstrating a tachycardia which is not settling down, usually within 18 to 24 hours of the surgery, usually things will settle down. But if there is a persistent tachycardia, then keep one thing in mind, that there could have been something in the bowel which you should suspect. Do not miss out on that. Do not wait for your drain fluid to start showing fecal matter. Do not do any of these types of things. All right. A persistent tachycardia is something which is going to be your first warning sign as far as this particular bowel injury or a suspicion of a bowel injury is concerned. Right. Now, coming to the third thing. Though a lot of people will say that there is some controversy as far as giving bowel preparation versus not giving bowel preparation is concerned, if you are a practicing gynecologist who is predominantly operating onto the lower bowel, that means if you are predominantly operating on the sigmoid and the rectum, these two are the places where we predominantly operate upon. If you are operating here, okay, then it is very wise to have that part of the bowel as an empty bowel. The reason why is because there is an abnormal amount of gaseous distension which can be handled by both the sigmoid as well as the rectum. Because sigmoid is the place where you have stool storage and rectum is the place which is a high pressure zone as far as manometry is concerned, where there can be a lot of passage of stools in a lot of force following the gastrocolic reflex. So if in case you plan to repair these two parts of the bowel, we encourage you to maintain bowel preparation and to have a clean bowel. That is important. You may choose to not give bowel preparation when you are doing ileocecal anastomosis, when you are doing ileal anastomosis, you are operating on the small small bowel. In all these places, bowel preparation may or may not have a role. But in our situations, in a gynecological situations, do not fall for that practice that you want an empty bowel. I also want to point out a lot of things as far as that important study was concerned, is that majority of the surgical procedures which were carried out as a part of that colonic study were for laparotomy. So what typically happens in laparotomy is you can squeeze the bowel out from both the sides, empty out the stools from there, stools go on a gauze piece, and the bowel which you are anastomosing is still an empty bowel. Understanding? And that is usually not possible when you are doing laparoscopic surgery, and that's why you should have a well prepared bowel in laparoscopic surgery. Right? That was point number 3. Coming to point number 4. A lot of times in our counseling as surgeons, we hear from people that, I am scared of doing endometriosis surgery because somebody has told me that you will require to do a colostomy. Or somebody has told me that, you will require to do an ileostomy. Fine. So there is a massive difference why we would recommend an ileostomy as compared to a colorectal surgeon recommending an ileostomy. If you see, the predominant segmental resection and anastomosis which is done by our colorectal colleagues is for patients who are having a malignancy. And if you study, like we have a onco unit here in our hospital, so I'm very close to them because I do some endoscopic work with them, and they call me for some of their resections. So if you ever touch a malignant bowel, you will realize one thing. Lot of these patients would have received a short course of pre-surgical radiation to reduce locoregional disease. A lot of them would have received 2 or 3 or 4 cycles of chemotherapy, and then they are posted for surgery. What typically happens in that situation is, because of the local pelvic radiation, there is already a good amount of microvascular damage which has occurred to the local area of the rectum. And our colorectal colleagues would recommend a temporary diversion ileostomy because the bowel which they have anastomosed is not a greatly vascular bowel. This is the exact reverse of what happens in endometriosis. Everybody would agree to me that in endometriosis you have good amount of neovascularization at the region where the lesion is. So when you do segmental resection and anastomosis, these patients do not require a mandatory ileostomy. Yes, there are definite indications for doing ileostomy, especially when the lesion size is more than 6 centimeters and it is less than 5 centimeters from the anal verge. That means it is very close to the levator ani muscle where there is high tension. In that situation, in order to avoid a fistula, you can have a temporary ileostomy. So on an average, we will do around 7 to 10 ileostomies in a year, and that is predominantly because we have such a high volume of operating low anal disease all across the country. So I am talking of 7 to 10 ileostomies across India. And that is a very small number if you compare to the total number of surgical procedures which we will be doing for this disease in the country. So that is an important take-home point. And the final important take-home point, alright? Whenever there is a leak in the bowel, there are 3 important things which you have to do. One is diversion. No questions asked, do diversion. Do not fidget with that region, just do diversion. Second, most of the times, the patient, by the time we recognize and we intervene, the patient will require an ICU backup. So kindly operate these patients in an ICU backup because fecal peritonitis otherwise carries a mortality of in excess of 30% even for young patients. If the patient is an old patient, let's say 50, 60, whatever, though fortunately we don't get so much endometriosis in that age group, but if you see an old patient with fecal peritonitis, the mortality rate is more than 50%. And if you add any comorbidities to this, for example, if the patient is a pre-existent diabetic, pre-existent, let's say hypertensive or whatever, pre-existent autoimmune condition, whatever, in that situation, the mortality would cross 65%, right? So one has to be careful that if you recognize this, kindly take the patient to a place where you have a backup of an ICU available, because this patient, majority of the time, you will realize that as soon as your diversion is done and if the patient has been compromised, your anesthetist is not going to allow the patient to come out of the ventilator. And most of the times the patient is going to be shifted in the ICU on a venti. And the patient will be on a venti and on NORAD support, that means cardiac support, for the next 48 hours. Usually the patient turns back in that situation, and that is when you are going to be relieved. So that is an important point number 2. And point number 3. And I think this is an important take-home point for everybody. Please, when you start operating on endometriosis, please start taking procedure-specific consent for every endometriotic pathology which you are operating. For example, if you are operating on cecal endometriosis, take procedure-specific consent for cecal endometriosis. If you are operating discoid excision, take procedure-specific consent for discoid excision. If you are doing segmental resection, take a procedure-specific consent for bowel resection. And I think that is going to give you a good night's sleep as far as continuously handling bowel endometriosis is concerned. Out of my experience for handling a good number of complications as far as bowel endometriosis goes. See, I am one of those lucky guys who has operated in every state, and that is why I have had a patient whom I have complicated in every state of India. Understanding? So I would have had a complicated patient in Gujarat, I would have somebody complicated in Bangalore, Chennai, Tamil Nadu. Everywhere where I go, because of the volume, you will have somebody or the other who has ended up in a complication. So there is no question in that. One thing I realized, the thing which really saves you at the end of the day is a good indemnity insurance as well. When you are operating so many these types of patients, if you are at this level operating these patients, kindly upgrade your indemnity insurances to more than 20 crores and do not stay at that 5 crores and 2 crores mark, because that may or may not be sufficient to take care of your things, right? Some more points which may or may not be take-home points, but I think they are important points as far as management of bowel endometriosis is concerned. Okay, in order to avoid the complications, I love to do a good pre-operative ultrasound. If the bowel disease is more than 3 centimeters in size, okay, majority of the times the patient would require a segmental bowel resection, and it is good to counsel these patients for a segmental bowel resection before the actual surgical procedure would start, right? Majority of the times, a disease in the bowel which is less than 1.5 centimeters in size, and on axial ultrasound, if it is occupying less than 15% of the circumference, 1.5, these are the lesions which do not require segmental resection. They will heal beautifully well with a discoid excision. Okay. One last point before which I think, since I have also finished 15 minutes, I also want some time for discussion and not to prolong the program. If there is a primary injury of the bowel in your endometriosis surgery, we have shifted exclusively to suturing it back using Stratafix. We do not use silk, we do not use PDS, we use Stratafix. Number one, you can use either Stratafix. We use a combination of Stratafix and Quill both, okay, and both are extremely good as far as bowel healing is concerned. Single layer suturing over the bowel, okay, in the same plane in which the incision is, and that really helps. And now is my final point. If you have done a segmental resection or injured the bowel, the first thing you should do is start the patient on early fluids within approximately 8 to 12 hours of the procedure. So I know this is debatable, and people are going to tell you that this is not done. You need to keep the patient NBM because your anastomosis is new. But remember one thing, because the anastomosis is new, you do not want paralytic ileus to set in. If there is a paralytic ileus setting in, the gaseous distension of the paralytic ileus itself causes a huge amount of tension on that anastomosis, thereby weakening that anastomosis. And as a result of this, on the second post-operative day, that means 24 hours after surgery, make it a rule to monitor the electrolytes, make it a rule to monitor the albumin. Remember, albumin has to be corrected, potassium has to be corrected, and these are two potentially correctable points for reducing complications of your bowel procedures, right? Finally, one medico-legal thing which people will ask, so I'll just answer that do we keep a colorectal surgeon or a gastrosurgeon or a oncosurgeon with us in the team when we are operating bowel endometriosis? So I think the answer to that question is very straightforward. God has been kind to us that we have not lost a court case. We have filed PILs for this, and nothing has gone against a gynecologist doing a procedure which is mentioned in his or her textbook, which is a standardized textbook. So fortunately, if you look at gynecological surgical textbooks, they have started mentioning bowel endometriosis as a separate chapter. And if bowel endometriosis is mentioned as a separate chapter, as long as you are trained in it, you should be in a position to handle these things on your own. But in today's time and age, to be very honest with all of you, okay, I started off with a private setup with an individual practice, and now I am into a corporate hospital of my own. So what typically happens is, in a corporate setup, you have people available with you in and around you at a whisker. Okay, so if in case I require anybody for anything, I have absolutely no shame in calling people and making them sign and keeping them in the operation theatre, so that post-operatively it is 4 doctors going and speaking to one patient, or 4 relatives and 4 doctors are speaking. compared to one doctor speaking to 15 relatives. So if you start developing this, then what typically happens is the headache gets distributed between 5 people. This is just my experience and I reserve the right to be wrong. I am a small man and I am a young man. I'm not as experienced as majority of the senior colleagues which are present here. But this is my experience from my limited understanding, that if you have 4 or 5 people with you in the operation theatre, and when people see now that these guys have really worked hard in order to pull the patient out of a complication, the relatives and everybody usually calm down. And once they calm down, they become more receptive to listen to you as far as the negative implications of the disease are concerned. Because in bowel complications, you will face patients where there is a renal shutdown. You will face patients who has, developed a hospital-acquired infection, venti-acquired infection, urine output is not coming, something is going to go wrong. And your post-operative state, post-fecal peritonitis is very, very unpredictable. So what we do here is that we tell everybody that the standard post-operative stay in the hospital is going to be 15 days. That is what we start with. We know it normally settles down in 6 to 10 days, but we tell 15 days. So everybody knows that for 15 days, we are not supposed to bother these guys as to why did you say 15th day and now it is the 16th day. So we have to listen to that drama on the 16th day. Understanding? And I think if you are running a unit where you are handling fecal peritonitis as frequently as I do, then I think maintaining something like this or or having something like this in your armamentarium might help you. With that, I conclude. I really thank all of you, Kalyan sir, Mala ma'am, Sujal bhai, Devan bhai, and everybody, and Ankur for giving me this opportunity, and hopefully I shall be able to answer some questions.
Thank you, Jay, for very, very, very insightful discussion. I think forum is open for all of us. I just wanted to know, you must be encountering lower anterior resection syndrome also.
Yeah.
How do you counsel patient and how do you treat it?
Yeah, that's a great question. So one important thing for LARS, it's really tough to predict who will get LARS. Okay, but if there is a loss of bowel segment of more than 10 centimeters, especially for the long bowel, large bowel, the possibility of an unsettling LARS is pretty common. And this may continue for a prolonged period of time because it is very difficult to understand how it will respond to and when it will respond to, and it is troublesome. So there is no question about that, isn't it? So what we normally try to do is we have a good addition inside our consent for women who are undergoing a segmental bowel resection of more than 15 centimeters. We tell them beforehand that this is going to happen, and usually they accept it very nicely. All the therapies which you try to give, right from nerve relaxation strategies to probiotics to intestinal motility reducing agents, I think a lot of problem these people face is not from the passage of frequent stools. They face a lot of social discomfort when it comes to passage of frequent flatus. And that is something which they don't like. But I think, as you mentioned, it is very difficult for us to control.
So when you have multiple lesions, how do you manage multiple lesions?
See, if the lesions are less than 5 centimeters apart, then you will have to resect that entire segment together only, madam. Because otherwise the anastomotic site will not hold through. But if in case you have 2 satellite lesions which are 15 centimeters apart, then it is better to resect them individually only.
So what is your cutoff for discoid and segmental?
As I mentioned, any lesion which is 1.5 centimeters in size and less than 15-20% in circumference of the bowel, disc will usually suffice. But if the lesion is larger, if the lesion is, let's say, 2.5 centimeters, sometimes you may not even get a complete disc. And in the bargain of just doing a disc, you should remember that particular part of the disc should not undergo some stenosis at that anterolateral part where the disc has been taken. If that happens, then it is a big problem because it can cause post-surgical constipation in the long run to the patient. So that should not happen, ma'am.
Have you ever encountered in a small bowel the lesions?
So small bowel endometriosis and resection is something we will end up doing close to 4 cases to 6 cases in a month. The typical sites where small bowel is involved is where the ileum has gone and got stuck to the ovary, and appendix is also stuck there, and there is a nodule which is impinged on the ileum and the appendix both. So usually it is going to be something like that, but very rare to see isolated small bowel endometriosis in an otherwise normal pelvis. So that is pretty rare to see.
Yeah.
Dr. Jay, there's one question that has come from the delegates. They're asking, as far as bowel endometriosis is concerned, what is the role of preoperative endorectal MRI?
I don't do it. I don't think it is mandatory either. I mean, see, majority of the times what happens, I'll tell you. All these investigations will be done because patient is having chronic pelvic pain. Somebody will put a colonoscope and take a biopsy from a bulge on one of the sites in the rectum, and that's going to turn out to be endometriosis, and then somebody is going to tell you, oh, this is endometriosis. Okay, go and get operated. Something like that. That's the most common thing which happens. We don't recommend it because here we have a very, very good in-house ultrasound unit, as all of you are aware. And because we have an excellent ultrasound unit, we probably don't feel the need for an MRI.
Okay, is it okay in case of medical legal aspect? Won't you be questioned when you have some kind of a complication why an MRI wasn't done?
No,
right?
no. In MRI also ultimately tells you that you need to correlate clinically. So as long as an investigation is then not the foolproof investigation or a 100% investigation, the 3D ultrasound and MRI both hold the same value in the court of law.
How is an small bowel lesion in
extrapelvic endometriosis MRI is
how the pelvis?
I think two questions came together. Devan Bhai and Sujal Bhai both asked together.
Yes, I completely agree with them, Dr. Jay, that probably sonography is sufficient, but extrapelvic endometriosis MRI has some definite role. That is what I was.
Yeah. I mean, see, if there is an extrapelvic endometriosis, especially upper abdomen, then doing MRI is really, really important. But one thing we must understand is that if your hands get good at picking up almost everything on ultrasound, believe me, apart from thoracic endometriosis and diaphragmatic endometriosis, which ways ultrasound cannot pick up, you will be actually able to pinpoint and pick up most of it. That is just my personal submission, but that cannot be generalized. Yeah.
Yes. Devan, you were telling something, Dr. Devan?
No, same question, sir. I was asking same question, that what about the above pelvis? When in TVS actually we are saying Vismay, he's doing very good ultrasound clips and all, Jay is doing very good in TVS and picking up nodules and almost 95 to 98% or 99%. But then what about upper abdomen?
No, upper abdomen, Devan Bhai, if in case you are suspecting, it is better to do an MRI unless you have the type of ultrasound grooming which we have. See, we have made mistakes in the past on ultrasound, and what we thought was endometriosis was just an angiolipoma. What we thought was an angiolipoma was an endometriosis. So all these mistakes have happened by us in the past, and not that we regret those mistakes, but I think we learn from them. And when you end up learning from them, the next time you do the same characterization, your life will become much faster and much more easier for you as a surgeon and for somebody as a patient. So I think training is the deficit is training. The problem with ultrasound is it is not very reproducible. See, if Visma is trying to pick up something on ultrasound, he may pick up 5% better than what I may pick up, and maybe I may pick up 5% less than what Devan Bhai may pick up. With MRI, what happens is that because the patient is in a static position, see, ultrasound is also dependent on dynamic movement in the pelvis, right? MRI is not dependent on that. MRI is a static examination. Patient has gone in the machine, one report will come. As long as the report comes in a particular manner, and if you are even a decent radiologist, you will be able to pick up what is adherent where. There is no question marks in that, isn't it?
Second is that MRI documentation remains with you for a very long time. And what happens, you can review it also. That is also an added advantage. And for patient counseling also sometimes, to show it to the patient, because on sonography, sometimes that is what I feel is difficult.
No, I one for a tip for everybody who likes to do pelvic MRI, kindly do pelvic MRI suspecting endometriosis only and only with gel contrast. Do not end up doing pelvic endometriosis suspicion. Do not do an MRI pelvis. That has got nothing. You need to do an MRI pelvis if you want to do with gel contrast. Otherwise, you don't do it. As simple as that. So, because you need a distended bowel on MRI, simple. You need a distended bowel and you need a contrast in the vagina to identify invasion. Otherwise, in a collapsed bowel, you are not going to be identifying an invasion. And most of the times you've seen MRI suggestive of little adhesion here. And that little adhesion is actually a 4 centimeter nodule. So, those can happen if gel contrast is not given to the patient.
So, would like to add something about Sujal Bhai. What Sujal Bhai was saying, that he's absolutely right in saying that when ultrasound you do on your own, that's your own document. So when MRI or ultrasound is done by someone else and documented with a sign and stamp, it becomes a document that not only we see this is the report, which also suggestive of something like in endometriosis also. Second thing, what Jai Bhai is saying that if you many times what consultant writes it is only MRI pelvis, then patient comes with report and there is nothing more. So if it is rectal and vaginal gel, and if it is good prepared bowel like Dalcolex you give you and partially filled bladder, there are a few criteria which we follow. If there are hyperperistaltic bowel, we give injection buscopan. We ask that radiologist to do ultrasound first and see, and then do MRI. There are a few points which, if you follow, your MRI report becomes really good and you can pick up. Second thing is, when you do MRI, you start reading MRI also with your radiologist friend, and also you can correlate between MRI and actually you are going to operate after that particular MRI. So that way you can you can learn, like we were discussing about.
So I would recommend to every viewer who is listening, there is a beautiful mobile phone app which is available called the DICOM app. Okay, and if you just download that on your phone, wherever anybody is getting an MRI done, the radiologist can simply push the code to your phone, okay, and you will be able to access the MRI. The beauty starts after the surgery, where you tried to read an MRI before and you went wrong 50 to 70% in the first reading, okay, and then if you do this over a prolonged period of time, let's say if you do this over a 1 year window, you will realize that your MRI reporting will become actually very good. You will be able to pinpoint small things in an MRI, and you will be able to counsel the patient much more than that radiologist report. This is my.
I agree with congratulate the Mayflower team here.
Yes.
They have sensitized radiologists so much that now Gujarat at least, the MRI reporting of endometriosis has gone to a different level. I must congratulate the whole team here.
Yes, sir. I would also add, sir, because I have seen patients who come to, I am in Pune, but even in Delhi or Pune, whenever a patient has been seen by any one of us in Gujarat, the MRI reporting for endometriosis that has come to me and has let me know doubts about the whole protocol that the Mehta team has set up. In fact, they've also told us how, with Dr. Lakshman and Dr. Sanjay, they also told us how to read our own MRI. That was one of the major highlights of our training that we had in Mehta. We would read the MRIs on our own, disregarding the report completely. So I would say that doing our own scans, not relying on the ultrasound finding of the radiologist and reading an MRI, would form a very good basis to help our own pre-operative evaluation of the patient.
So what is the tab?
Sujal, can I come?
Yes, please.
Just do the only simple MRI is not enough. You train the MRI center. In our center, I think every Saturday we do the reading. Those who will be done the 7, 10, 50 cases in this week, try to make we do the interactions with our radiology MRI people, and then it's updating what the Jay is telling. The training is the most important part. I do not personally believe that the 100% sonography is not conclusive, because in this era, I think we started with the transvaginal sonography. Even though we put a lot of gel in the rectum and we do the sonography and we do the transrectal sonography. At that time also we go for the colonoscopy in all the cases before 15 years. Now we stop it because there is so
very difficult to find out anything. But the most important part in our practice, we realize that MRI is considered to be one of the best. There is no question at all. There is a lot of limitations with the sonography because we have the dedicated 3D 4D sonography unit. We try to make the, even though we every day we correlate, we do the sonography, we operated this case, and then we come with the conclusion. Majority time with the experience and with the so much training, I think up to the 90% we take the judgment related to pelvic endometriosis with the sonography. I think if you train the MRI people, MRI centers, I think up to the 98% accuracy we get it. Small bowel endometriosis, one of the points I think I'm adding, due to the mobility of the small bowel, I think small bowel endometriosis ratio is very less. The majority time what we identify the appendix is coming involved and some part of the ileum is involved. But the specific segment